symptomatic, we count 2 days backwards. We could also include among contacts. There are people, we tell them, you are a contact, stay at home. Then they sneak out, they go to the supermarket. We won't see you, no problem. Others go to their kids, others go to visit friends, others go to the party. However important the activity is, please try to ensure that you adhere to the contact tracing standards. I am going to go through some of the precautions. These are really around what WHO has been doing, but the other agencies can explore and see if it is possible, especially around the general approach to the office. Now, make sure that the workplaces are clean and hygienic, especially your desk and tables, even the phones, keyboard. Make sure you wipe them with alcohol at least 3 times daily. At least 3 times daily, yes. Wipe them. It is not to put too much alcohol, but ensure that you wipe them so that they can be clean. Yes. And this is important. Deep cleaning of the offices will be important, supervised by a safety officer. At least each agency should ensure that they have someone who is a safety officer or an IPC person. If one is available, you need to ensure that the office is thoroughly clean at least every week. Employees, visitors entering the office should regularly and thoroughly wash their hands with soap and water, and then they should also use hand sanitizer regularly. We are all of us at office at WHO. We actually do self-policing. If we see you without a mask, we really ensure that you put on the mask, and everybody is really so alert about putting on the mask, and each of us is checking each other. So we need to be balanced to each other. Otherwise, these violations can get us infected. And sanitizing of hand is important, especially within the office. For us at WHO, we have automated hand sanitizers, which we are using, and we encourage other agencies, if it is possible, they could also explore that. For meetings, think twice before you organize a face-to-face meeting. Before you organize a face-to-face meeting, think twice. If you can replace it with a teleconference or online or any other visual method, this might be more safer for you. And it is really extremely complicated to have meetings. And some people are organizing workshops of 100 people, others are organizing of 200 people. Then you will need to provide them with the meals. At that time, they will take out the mask. Then they will go to washrooms, and some have taken off the mask. Then they are in small gathering and they have taken out the mask. This can become a transmission point. So before we organize a meeting, we need to think twice. We need to reduce the number of physical meetings as much as possible within the office. We need to keep the distance of 2 meters between people who are in the meeting, or at least the ones sharing offices. For some of us who share offices, ensure that your distance is far enough. And then meetings that last longer than 15 minutes is actually discouraged. You should have those meetings in the boardroom, or you should use Zoom. A meeting in offices, if it is going to last more than 15 minutes, is not encouraged. You should either use boardrooms or use Zoom. Yeah, if meetings occur in the boardroom, social distancing is still required. I know people will say, we are in the boardroom, we are more than 2 meters apart. We remove the mask, we remove the watch. No, everybody should be on mask, because you do not know what happens with ventilation, you do not know what happens with aeration, and this can also be a problem, especially if people are talking well and high and the mask is not well fitting. All organizers, participants, and visitors in the meeting should be recorded properly. We have had some incidences where we have problems struggling to get this. Ensure that you record phone numbers, email addresses, and proper names of people who have attended. This is critical in contact tracing and in control of the outbreak. I've already talked about hand washing and use of alcohol and wrap. Yeah, if someone at the meeting or was isolated or suspected for COVID-19, all the other people who attended the meeting become contacts, they should remain in home quarantine until 14 days, and they should take temperatures twice daily. And if you develop anything of cough, or let us call it allergy, or any feeling of unwell, you need to be what? You need to be checked. You need to call for help, especially if you are in contact with those people. There are also issues. We need to assess the corridors. Yes.
Access to the corridors should be yes, based on risk assessment. Before you decide to move from your office to the corridor, you really need to assess whether you are at risk or you are not at risk. Don't be loitering, yes, conversing in the corridors, and then yes, staying and then moving from one place to the other one. Because if you become positive, you could have exposed so many people, for which case we have to ground the entire people in the office, and this is really not a good thing. Let us ensure we enter into our office. If we have to do any exercises, let us do it within our office. If we are using any of the public facilities, let us go use it quickly and go back to one place. And yes, and then we do our exercises when we are in safe places at home. Now, on mission, this is another place of trouble. On mission, yes, we need to assess the travel plan based on the risk or benefit vis-a-vis the travel itself. Before you travel, think twice whether you need to do the travel or you have an alternative. Because travel generally creates its own vulnerability. You are going to be at several airports. You are going to be at several airports. You are going to do a lot of maneuvers. Yes, mask will be there, but mask is not any guarantee. Alcohol and wrap will be there. There's no any guarantee. Nonetheless, you should ensure that you use your mask religiously as you travel, and clean your hand as often as possible. If you see anyone looking unwell, try to dodge them. Move away from them to 2 meters or something like that. All the staffs who return from mission should be on quarantine. On quarantine, the days are at 10, but this could be negotiable because scientifically 14 days. But for now, I think the regulation says 10 days. And you have to test negative before you are discharged from that quarantine. Now, when you are from travel, it doesn't mean when you're in quarantine, you should be seen in the supermarket, you should be seen in the arcade, you should be seen in church, you should go to your friend's place because it's boring to stay for 10 days inside the house. No, you are in quarantine, you are in self-quarantine, you need to stay at home until the days are finished and you have tested negative and has been officially discharged. So yes, all the staff who return from mission shall quarantine themselves and monitor. If you develop any symptoms, report. You need to report. You need to report, and that really is the issue there. If you develop any issues of fever and cough, you need to ensure that you report urgently to the UR clinic. Dr. Tefera and his team and the IOM team are available. Also ourselves, we can provide backups to be able to ensure that you get the care that is required. Now, you need to, the best practices that we can cite as WHO is that we have constant supply of disinfectants in our offices for all the staffs, despite all the difficulties that we have in accessing them from the market. All the staffs have thermometers and they are able to monitor their temperature whenever they feel like. All the staffs with the flu, stay at home. Stay at home. There is no coming. Stay at home. As long as you report, I have flu, you will stay at home, and we will usually check them to ensure that it is not COVID-19 because of the risk. Staffs are also, we also monitor closely the issue of compliance with the use of mask, and we have yes, we have PIP teams who are monitoring. If we find you without mask, we will ask you to put on the mask. In any case, we can also tell you to work from home. Staff use the same drivers when in the field. Yes, there are in the field you can have 14 fleets. Please attach staffs to the same, preferably to the same cars, every time, so that if there is a situation, you do not have all your staff members in the field contacts, because they were, for instance, if the driver was the one sick, then all the occupants day by day from the time they are noted will be contacts, and this will not be a good thing. So let's attach a specific number of staff to specific whatever. Deep cleaning of the office every weekend this is really done, and for us is supervised by there are these challenges that I want you to pay attention to. Non-adherence to follow up to follow up SOPs. There are people who do not want to adhere to follow up. They are giving a headache to everyone. You try they put off their phones. They put off, yes. Yes, there are even some who are on home-based care. They want to get out to go to the supermarket. Some are contacts. By the time you want them, then you hear they are moved from one town to the other one, and yet they have taken samples as contact. For as long as you have taken samples for COVID-19, you should not move. You should stay in self-quarantine until you receive your results. Because if it turns out positive, all these people you will have increased the number of contacts and also the risk of people getting sick. If you are a contact, I've already said stay at home. We are seeing increasing number of dependents. We are attributing this to non-compliance with self-isolation. Yes, we have agreed that UN staff should stay in self-isolation at home. There you have better environment, you have better support from your family, you eat the food that is available at home, and it is better overall. However, we are seeing also that those people who are making your life stay at home better are the ones that are actually getting sick. So this is really not a good observation. We continue to monitor this as a technical team. We might advise otherwise if we continue to see this trend. A quiet enrollment to home-based care. There are people, they do the COVID-19 testing, they find they're positive, then they stay, they don't inform anyone. They stay quiet. And then when the situation becomes sick, then they start informing. And this is really not a good thing. Let us ensure that we inform our head of office, we inform the UN clinic, yes, so that the UN clinic can then give us the information, the rest of the medical team. Late seeking of care, there are people who know a lot of medicines. Whenever they feel headache, then they say, I have this one. Then they go to the pharmacy, they buy. By the time you remember it is COVID-19, it is too late for you and it will not be good. There are people who are not cooperating well with the people who are on contact follow-up and also on their device. I think this is something that we need to work on and ensure that we can be able to cooperate so that we can work together to ensure that you are well through your time for follow-up. Yes, there are staffs who are at high risk. I have put some of them here. Yes, the people who are, yes, of age 50 years, 60 years, this and all have diabetes, heart diseases, lung problems, and this kind of comorbidities. These people develop serious sickness, illness, and also they are the ones at risk of death. So these ones will not be on home-based care. They should not be on home-based care. They have to declare themselves to the UN clinic, and they should be enrolled on clinical care at the hospital under close monitoring. Let me say this, that yes, don't try to cheat the medics, don't try to cheat the SOPs, because the virus is ready to catch you. Adhere religiously to the SOPs. I thank you very much. Thank you very much, RC. This is the end of my presentation.
Ladies and gentlemen, I think a round of applause for WHO for a fantastic presentation. Thank you so much, Dr. I think you can hear the claps virtually going on. I'm going to do this on everybody's behalf. Dear colleagues, for all of you sending messages, we will be sharing it as soon as Innocent and Alex send it to us. So Tatsu will send it out to all of you who have registered for the town hall. Tatsu, can you please put back up the agenda to confirm what is the next step? Is this where I invite IOM to complement before we open up for questions? And then I also want to say thank you very much for all of you who are posting your questions in the chat. If you can, please continue to do so, because then it makes it easier between Dr. Teferi and the others and Dr. Jonas to know what to answer to. Review on how they're contributing to the response. And I will then be asking all the colleagues to be ready for us to move into the questions and answers from staff. So IOM, over to you. Sanusi, you good? Can't hear him. As IOM comes online, please staff, if you're asking a question, if you can also just let you know which organization to help us organize the replies.
Thank you, Rosa. I'm good. My colleague Osula will make a presentation on behalf of IAM.
Thank you, Sanusi.
Rusra, we are ready to go. Are you here with us?
Where is Ursula? What is going on? Where is Ursula now? I'm in trouble.
Okay, I see Ursula's name on the attendance list. So maybe WHO colleagues for controlling as a host, can you upgrade Ursula to the panelist?
Just give the names again, please.
So you have that right as well. You can upgrade him. I am still looking for him.
Let's see.
Just mention the name again, please.
What is going on?
Actually, I lost her from the list of attendees right now. So I'm trying to look for her.
Sorry, colleagues. We are trying to get Ursula, or maybe trying to connect her. If we can, that's be good. Otherwise, I will ask the doctor to do it. Thank you.
The last one, what's the name? Read for me the name.
So can you repeat the name again so that we can assist?
It was supposed to be E. Urusra, but I
name-
lost her from the list of attendees.
The name is on the PowerPoint, Ursula.
Her name is Ursula. 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 Eyer. Ursula.
I think she lost her connection.
I have upgraded her, but let's see if she is there.
Ah, there you go. Yes, it
Yeah.
says she's co-host now. Thank you, Jonas. She's co-host. Ursula, over to you.
Ursula, you go ahead. I will unmute you.
Hello?
You are online. Please go ahead.
Okay, thank you so much. IOM services, this is under the flood response team. My name is Ursula Eyer. Let's go on. Yes, what are the services that we offer as IOM? And that is eligible to the UN staff and the dependents as well. We do laboratory services, and this is for COVID-19, and other laboratory tests are also available at the IOM clinic. MHAC means Migration Health Assessment Center. We also do clinical services that involves evaluation of the suspected COVID-19 cases, medical consultation, psychological support, as well as radiology services. We also offer telehealth, and that is through home monitoring of the contacts and patients who are in home-based care. We also do support in medical movement, and that is through medical escorts of any cases that need support in that event. Next slide, please. Hello. The next slide, please.
Ursula, which slide are we talking about? We are now on the how we care COVID-19. But
Yes.
would you move to another next slide?
We do sample collection also. For the COVID-19 patients, we do testing of the suspects who come in. We also monitor COVID-19 positive cases while in home isolation or home-based care. Then we keep in touch with the contacts of COVID-19 staff and facilitate their testing as well. Then in the field staff, we liaise with the surveillance teams, that is WHO, who are on ground, so that we enhance their testing and have them tested. We also conduct the home visits of the patients who are in home-based care whenever necessary. We also do escalation of care for the cases that require hospitalization, even that a patient in home-based care has symptoms that are increasing and becoming more severe and intense. We do escalate and support in hospitalization. All these activities are done under the leadership of the UN doctor in coordination with WHO and the Ministry of Health. In COVID coordination, the UN coordinator as well as IOM agreed that the roles based on the region structure of the UNCT. Medical focal points were assigned, and these regional medical focal points are assigned as per each area. Karamoja and Eastern covers also the central. Then we have the Northern region, has a doctor assigned to it. We have the Western region, and we have also the Western region. How do we do the communication flow? Communication to the regional medical focal points is received from the following about a staff who is positive or an alert or a contact who is in isolation. We receive communication from the UN agency, from the HR, from the other admins who are in office. We also receive sometimes from different doctors who are within those agencies. Sometimes we also receive this information from the UN COVID coordinator or the UN doctor, the UN clinic, or the staff themselves may directly reach to us and inform us of this. What do we do? Counseling and psychosocial care is very paramount in home monitoring. We do advise staff to stay at home and monitor your health. You must not leave your house if you are self-isolating. Stay home for 14 days after your last contact with a person who has COVID-19. Then watch for fever, cough, shortness of breath, or any symptoms of COVID-19 as detailed by Dr. Innocent. Then if possible, we also say that stay away from others, especially people who are at high risk of getting very sick with COVID-19. Those are the vulnerable groups of people. What to do when you are in home isolation? We always encourage that make use of disposable material more than the reusable material, because when you're isolating at home, you're dealing with other family members. It means that as they are home, you have to protect them. So using more of the disposable, it's easily to discard than the reusable where they have to wash and get it back into service. We encourage that use mask always at all times, have your mask on. That is part of respiratory hygiene. We encourage you to practice hand hygiene, wash with soap and water, enough soap and water, use the hand sanitizer as well. We encourage physical distancing in times of receiving supplies and deliveries. Then, because in this case, when you're in home isolation, most of the times you find that you'll opt for the online services, or you'll ask someone to buy for you and drop it near your home. So always maintain that distance when they're delivering, or ask them to place it somewhere, then you pick it from there. Then we also encourage monitor your temperature when you're home. To most of the people, we have been giving them the home monitoring kit. So we ask you to monitor your temperature in the mornings and in the evenings. Then continue with your medication. If you have any underlying medical condition, please, while you're in isolation, continue taking your other medication. Tell the people you have been in touch with, in close contact with, to get tested. If they have symptoms, or if they are alerts, or if they are contacts, tell them to be tested. Then also alert the medical team when your symptoms are worsening. What should you do? What you shouldn't do when in home isolation? Do not go on public transport or taxis. Do not go to work, to school, or public places. Do not go out to exercise, but rather you can exercise within your home. Then we also encourage that do not go out to get food and medicine, but rather order it online or phone or ask someone to bring it to your home and drop it nearby, and you just go out, pick it, and get back into the isolation. That is in the event that you are alone. Then we also say that you should not have visitors in your home, including friends, families, except the people who are providing you the essential services. Because in this case, you're isolating. So if anyone, sometimes we have the African tradition, people love visiting a lot, but we say that if you are in isolation for COVID, we do not encourage visitors into the home to avoid spread. Then do not share the washroom or any other reusable materials at home, so that we avoid spread of the virus from one person to another. What are the lessons we have learned during this time? We have learned that before doing an evacuation, because we have done, with the team together, we've done close to 19 evacuations of staff from up country. We have learned that we should ascertain the legal status of the dependents in case they also have to be evacuated. Then we have also learned that family support means a lot in this response. We have also learned that it's good for the staff to have all their documents close by, the passports, the vaccination certificates. In the event that this staff will need a medical evacuation, we don't need to search to different places, but it will be readily available because they are part of the documents needed. Then we have also learned that it's just good to prepare the patient for the hospital environment and to also know what they'll expect as they go there. Then also staff should not keep in hiding with symptoms. Early management and intervention saves life. In conclusion, working with other UN agencies on staff health, IOM has worked collaboratively with other UN agencies on staff health, including specifically the RCO, the UN doctor, and WHO. WHO has been involved in providing technical guidance, patient guidance, investigation of contacts, disinfection of premises, and providing a linkage with Mulago Hospital for admission to the private wing. These entities have also been involved in coordination with 2 medvacs that have so far been carried out. Thank you so much. Thank you.
No, thank you very much for that. And I think that we now open it for the question and answer session. So please identify yourself, convey your question, and we will make sure that you get a response. So who wants to go first?
It needs moderation, so I'll try to moderate. Loting, I ask you to speak.
Anybody raise your hand or with a message? Oh,
Loting Sylvester.
Yeah, there you go.
Go ahead.
Okay, Rosa, if I may, can I go ahead? I received a couple of anonymous questions before this session started by email, so maybe I can read them. Is that okay for you?
Yeah, go ahead.
Sure. Okay, thank you very much, colleagues. I received 2 questions before this session started. the question number 1 was, if volunteer to check myself of COVID-19, assuming the result is positive and I am asymptomatic, will I still be taken to the treatment center, or is there a possibility to designate a cell home that I can isolate and receive the prescribed treatment? Here, I hear that the situation at the treatment center is scary and may cause more harm than good. That is question number 1. And I have one more question. Please let me read it first.
I just don't want to interrupt this, but you see this?
Sure. The question number 2, when one is sick of COVID-19 and not responding to, sorry.
Ursula, please mute yourself. Proceed, Tatsu.
Yeah. Okay, sure. Thank you. So the question number 2 is, when one is sick of COVID-19 and not responding to in-country treatment, at what stage will the patient qualify to be referred and evacuated for specialized treatment? For example, in Nairobi, probably need to streamline the procedures, which may be bureaucratic, tedious, long, and might not be life-saving at the end. So those are the 2 questions received on anonymous basis before this session started. Maybe we could start with these questions. Thank you very much.
No, thank you, Tatsu, but there's people who have their hands raised.
Rosa, if I may, maybe I would help in directing some of the questions to those who would answer.
Okay.
For the first question on home-based care, I would ask Alex to respond.
Thank you, Deborah. Thank you very much, RC. On the issue of asymptomatic cases, the current position from the ministry is that there is a provision for home-based care, but for one to qualify for home-based care, they have to do an assessment at the particular home which that person is going to be residing. There's supposed to be sufficient room, supposed to be water, sanitary facilities, and the room should be well ventilated. And there's supposed to be a person who's going to take care of that particular individual when it comes home-based care. So there is an option for home-based care which can take place, just to answer that particular question. But an assessment has to be done, and you have to qualify for that. So once you qualify for that, it means that you need to get in constant touch with the nearest health facility who will be monitoring you as your symptoms progress or they don't progress. So that is the bottom line on the show for home-based care.
Thank you, Alex. On Medivac and our experience on Medivac, I will ask Dr. Tafari to respond.
Thank you, Dr. Jonas. Yes, the Medivac system is always available, and it is not as described by the requester. Medivac is, when required, the doctors on the ground will alert the Geneva medical team that there is a potential evacuee. Therefore, the communication will start that day. It's very early in the course of illness. When a patient gets more sicker, this alert system will kick in. Therefore, there is communication, and in our experience, we have evacuated a case within 24 hours in both cases. So there is no delay when it is required. Though there are many processes, these processes could be done in due time. Yes, thank you.
Thank you very much. I would ask Zade from UNAIDS to have a question. Can you speak, Zade? A bit louder, I still can't hear you. You are mute again. Go ahead.
Hello?
Go
Can you
ahead.
hear me? I'm sorry, I couldn't hear.
We can hear you. Go ahead.
No, I said, I'm sorry, I didn't hear what you said. I couldn't hear.
You have your hands. What are the questions?
I don't think I have my hand. That was a mistake. I texted my question and that was answered. Thank you.
Okay, thank you. Stefan Muchunguzi, go ahead and ask your question.
It was a mistaken hand.
Okay. Robert Aktatia from WFP, your question. Robert? Okay. Dickens?
Jonas, as you call some of the people, I've posted some questions for you that are coming in from the chat. One is asking, is it true that COVID-19 infections go up during cold weather? Is there any relationship between COVID-19 and climate change? And I think after the person you're inviting, you also have Karusa on standby. Over back to you.
Okay, let me try to answer. It's likely that COVID cases would go up in the cold weather, not because of the weather itself, but because people will come indoor and that increases the risk. There is not, the evidence is not yet built whether there is a relation between COVID and climate change. As you know, this disease is very new and the sciences we know is limited. I can see that there are questions on vaccines. I will ask Annette to respond on vaccine issues. Annette, you have the floor.
Thank you, Deborah. I've not had a look at the questions, but probably I can just summarize that. Number one, the government of Uganda is part of the COVAX facility, and the COVAX facility is basically trying to ensure that there's equity distribution of the vaccines once they are available. So at the moment, the country has started developing a deployment and vaccination strategy plan. A readiness assessment has started. We've done the first one as of end of October, and the next one will be done as the end of November to see what are the gaps, what do we need to fix, so that by the time the vaccine is available, probably around the first quarter of 2021, then we'll be able to administer the vaccine. Now, who will be eligible? Now, the COVAX facility is recommending that the target will be 20% of the total population of each country. Now, the 20% is further subdivided into 3%, which are basically the health workers and the essential care workers. Then the 17% are the other persons who are vulnerable, who have comorbidities or any other criteria. So discussions are still ongoing in the country to identify who are the 3%. Is it all the health workers? We're also going to further subdivide the health workers and the essential care workers. So hopefully by the end of this year, we should be having a vaccine development deployment plan and strategy. But we do not have a vaccine as yet, which has been pre-qualified by WHO. Neither is it part of the emergency use listing. So more information will be released to the countries, and then we'll be letting you know of the next steps. Over to you, WR.
Thank you. How the UN would fare on the vaccine, whether the UN would secure a special amount is not yet clear, but we'll keep you informed how beyond these criteria other means would be. I saw a question on recovery and immunity. People who have acquired COVID would get certain level of immunity for that strain of the disease. But rarely, and this has been documented in less than a dozen cases, a reinfection is possible. And usually the reinfection would be from a different strain of the same virus. But the recent publications are saying at least that is not affecting the immunity which is acquired, which may be acquired through vaccination. But these are areas which we will look into. Carusa, I give you the floor. I think I can see you on the...
Thank you so much, Dr. Jonas, as well as Rosa and the other colleagues. I wanted to just request Dr. Jonas to talk about the use of masks and the non-use of masks. As we know, in Uganda, close to 70% of people with COVID are asymptomatic, i.e. they don't even know they have it. They have no symptoms and they're just moving around. I'd like you to speak more elaborately, and I know Dr. Innocent talked about it, but I'd like you to speak a little bit more about that, because this might be our family members and we have no clue, number one. Number two is the fact that what is the evidence regarding how masks protect the person who is wearing? There was a lot of confusion about that masks only protect the person, the other people, not the person who's wearing. But now we know from the evidence, clarify that masks also protect you, i.e. if you're not wearing a mask, you're putting yourself out there and exposing yourself to whatever is being breathed out. If you can just elaborate on those 2 points, that would be very helpful. Thank you.
Okay. And until the day we have a vaccine and we can get the immunity, the most effective ways of prevention are the masks. Earlier, more and more of the evidence built on masks was how the mask will protect people around the person who is wearing the mask. But recent data has shown that it protects both the person who wears the mask as well as the person, people around it. This is very important because what is seen is the difference is significant. And even when you see the global numbers, it is striking that in cultures where mask has become a norm, almost a norm, basically in Southeast Asia and Western Pacific regions, we see the numbers to be far more less than what we see in Europe or the Americas. And that is partly attributed to the wearing of the mask. And you would wonder, if you are even in your house, in the presence of guests, you have to wear the mask. That is the only way you can protect them and you can protect yourselves. Even when you are in the office with the people you know, knowing the person does not guarantee that either you would infect that person or that person would transmit the disease towards you. So definitely the masks, there is the surgical masks, but we discourage surgical masks because we don't want the stock of surgical masks to be very low for the health workers not to have surgical masks. There is the N95, which is used in specialized situations, and those should be used by people in the ICUs, the lab technicians who are handling the COVID or other infectious materials. But the mask, one thing you have to check with your mask is that it is 3 layers with 2 closed layers and a filter in between. That is the standard which is encouraged to be produced here in Uganda. Actually, some of the infection prevention and control people say that with the 3 layers, you either reach or even exceed the level of protection you'll get from the surgical mask. And it is important that at the end of the day, you have that mask washed and ironed. And do not touch your mask frequently, because if there is any virus on the outside of it, you will touch with your hands, and whenever the next time you touch your eyes, nose, or mouth, you risk the transmission of the disease. So caring of the mask, as well as properly wearing and properly taking it off, is also important when one is using the masks. I think that hopefully transmits the message well. Okay, if no comments from Carusa, I see a person by the name Amono with his or her hands up. I would allow you to unmute and ask your question, if that was the question. Maybe it was by mistake. Okay, I give the floor to Grace Ruamushana. You can unmute and ask the question.
Thank you. My question was, if someone is asymptomatic, how long does the virus stay in their body? Thank you. Over.
Okay, maybe I would ask Innocent to reply to this question.
Thank you very much. There are several studies that have been done also for symptomatic cases, but by the 10th day, most of the people will only have virus particles that may not be transmissible anymore. So for at least 10 days, this person will be infectious. After 10 days, then the risk of being infectious become low. But it will wane away. For Uganda, most of the people test negative on the 16th day. So that is how it is here. Thank you.
So the point is that your personal immunity or your personal fighting power would be able to control it within 10 days if you have that recovering strength. But if you are going to, it goes two ways. Either within 10 days you develop a symptom and then you recover from the symptoms, or your body will be able to fight it well within 10 days. That's why we usually insist 14 days to give a good time for the transmittability to decrease in cases. I give the floor for Maria Megezi, who has put up her hand. You have the floor, Maria. You may unmute and ask your question. Okay, maybe it's a mistake. Okay, I don't see her anymore. Antonio Ntungwa, you can talk and unmute to ask your question. Anthony, I don't see. Okay, maybe it's a mistake. Maybe I would ask Tatsu to read some of the questions and post them so that we can distribute them to the colleagues. Tatsu, you have the floor.
Sure. Thank you very much, Jonas. There are a couple of questions posted on the chat box, as well as questions and answer boxes. I first picked up a couple of questions from the chat box, and I randomly selected 5 questions in the chat box. Maybe we can start from there, and after that we can move into the questions and answers boxes. First, from the chat box, is the COVID testing at IOM open to all UN staff, UN staff and non-staff human resources, regardless of contract type. So this is a question to IOM. Maybe we can ask IOM colleagues to answer to this.
IOM, go ahead.
Yeah, thank you very much, colleagues. This is a question I can answer, and I could have asked my medical doctor to answer. But as far as I know, the further agreement we sign is open to UN staff and their dependents. As long as you are UN staff, you are holding UN contract and you are dependents, you are entitled to come to IOM to take your sample and send to the clinic and then wait for the results. So far, our clinic has already been certified to do the COVID test, but we are still putting some 1 or 2 things together to ensure that we run the test and then you get your result in less than 24 hours. This is my answer.
Tatsu, go
Sure.
ahead.
The next question is from a colleague in WFP. We have been told to improve our immune system. We have been told to take vitamins and supplements which are not covered under the insurance. In this case, what support? In this case, what support does the staff have? Maybe we can expect answers from the insurance side, and we can expect answers from these vitamins effectiveness, etc.
I can't answer the insurance aspect of it, but my suggestion would be, one, it's a good investment. If you can get your money back from the insurance, it would be good. But also, more than the tablets, it's important to get our vitamins from the foods we eat, vegetables and so forth. So yes, it's better to build our immunity with proper diets, and also ensure that we exercise and have a healthy living style, reducing alcohol and not using tobacco would be helpful in building our immunity, as well as put us in a better position in terms of our lung capacity and so forth, if by many misfortune we face COVID. But as for the insurance, I would suggest you discuss with your HR people in your own agencies. Over.
Thank you very much. Then the next question is, how is the community prepared for the COVID-19 recovered patients without stigma and discrimination?
I would throw this question either to Alex or to also if some colleagues from UNICEF could comment on psychosocial support, that would be good. Alex first, and then I will ask UNICEF to comment over.
Thank you very much, Dabia. Thank you, Tatsu. Issues of stigma have been raised in a number of communities, even for their relatives who have recovered. That has been noticed, and it's a common thing. But from the risk communication and community engagement part of it, this is one area which they are trying to address to make sure that as people go back to the communities are ready to receive them. The plan from the Ministry of Health, which was being implemented during the early stages of the outbreak, was that when someone is discharged, they are supposed to go back with the psychosocial team, who is supposed to go and prepare the relatives or the community before that person actually gets into their community. So this is how they've been doing it. But as the outbreak progressed, the teams of psychosocial was sort of outnumbered in terms of the patients who are supposed to be visited and the community supposed to be visited. So that area remains a little bit of a challenge. But we are saying that with the formation of the new community engagement pillar, this is something which, again, they're going to be focusing on. Thank you.
Sadrak, maybe you would like to comment on some of the good work UNICEF is doing in building psychosocial support in the communities. Over.
Yeah, thank you. I think Alex has covered it quite comprehensively, but I'll just add that we are working very closely with the Ministry of Health, really to have the support at subnational level on psychosocial support. This is really to look at cases where members of the community who are impacted upon can be provided with the extra support, really to deal with the mental aspects of the disease. So I'll just add that one, that we're working with the Ministry of Health, and I can provide more details later at a later point. Thanks, Dr. Jonas.
Thank you very much. Tatsu, the next question maybe.
Sure. Next two questions are short, so I will just read both of them together. So first question is, does a positive COVID antibody test confirm or suspect a COVID-19 condition have existed? What advice would you have? So this is basically asking about antibody test of the COVID-19. And next question is there any statistics on the gender dimension of COVID-19?
Thank you. I'll try to answer the question on antibody tests. The antibody tests are usually will tell us if a person has been exposed to COVID or COVID-like viruses. Part of the issue why we could not use antibody tests, for diagnosis is, one is it's up to now there has the reliability and the correlation is not as high as we would like it to be, one. Two, it is telling us about past exposure to coronaviruses, and there are a number of viruses in this category. So the most useful thing about antibody tests is it will help us in surveys to know how much of exposure in the general population is. On the other hand, the antigen test will tell us about an active case, provided that antigen test is reliable, specific. Currently, only 2 of the antigen tests have been pre-qualified by WHO. Although you will be told lots of and hundreds of antigen and antibody tests are there. They're used especially to diagnose COVID or for care of cases is not as much as we would like it to be. Except these 2 cases, 2 brands which have been qualified, WHO does not recommend antigen tests other than the 2, and we don't recommend antibody tests to be used for management or finding cases. I think that's what we have. The second question was, I forgot about it. Tatsu?
Yes, second question was gender dimension in terms of statistics.
We have gender statistics. Depending on, in Uganda, we were not thinking of that you wanted to know more detail about comorbidities and gender distribution and age distribution in this presentation, but we do have the gender distribution of cases over time as well, because as you remember in the first part of the Ugandan cases, they were mainly driven by truck drivers and importation. So there is a higher level of males in the first part of this pandemic, but we also have the gender distribution since when the lockdown was opened, and we will share that as part of a modified presentation which we'll give for UNRC, responding to some of the questions we said we'll get back to you with data. Over.
Sure, thank you very much. Then I have almost 25 questions now in the questions and answers box, so I will move to those questions. I may not touch upon some of the questions that seems to be already answered, but I will try to address, raise as many as possible. So the next question is from Grace Latiji. Have we considered whether staff have sufficient space for HBC? I don't understand what HBC stands for, but
that's home-based care.
Oh, sorry, home-based care. Okay, the space for home-based care. In an event that space is not enough, not sufficient enough, what are our options?
I think Alex has answered that there will be an assessment of the houses before agreeing on home-based care. Where it is not available, the space is not available, the Ministry of Health would consider institutional isolation. This is either in places like which has been converted from schools to facilities, or even Nambole is one of those facilities where people who cannot be isolated at home may get a free accommodation and care. But others have opted to go into hotels, and those options should be there. But the point is that for home-based care, a good assessment by the expert is required. Over.
Sure, thank you very much. And then the next question is the definition about the local transmission. Is it inter-regional or inter-district, etc.? So what is the definition of local transmission?
Alex?
Thank you very much, Dabian. When we started our outbreak in March 2013, we were referring to most of our cases coming from outside from the country, where the infection was actually coming from the truck drivers who were bringing the infection into the country. But the situation in which we are right now, we do not have truck drivers coming on board. Our situation is that the people within the same community are suffering from COVID, and that COVID is being transmitted from the cohort in the community from one person to the other. And that has been going on for a long time. So we're now saying that we have sustained transmission in the country, where we are not having any foreigner coming into the country with the virus, but the virus is within ourselves. So we talk of community transmission in that particular scenario. Thank you.
Okay, sure. Thank you very much. Then let's move to the next question. There is one question on antibody, but I think that was already answered. There is another question about IOM. What other services do they have? A, ultrasound screening, ECG, PCR test, X-ray, immunology screening. And there was related to IOM services. There was another question on the chat box. If the IOM COVID test is available for those people who are traveling overseas, those staff and the dependents who are traveling overseas. So maybe IOM colleagues could address those.
Go ahead, IOM colleague.
Thank you very much. Thank you very much, Dr. Jonas and Tatsu, of my in there, and that's one of my colleagues. the answer for this question, please. Thank you. Dr. Mokunda, please, if you are online, please answer this question. Okay, I'm not sure. I see Osula online. Osula, can you please provide answer to this question?
Good evening, members. Currently, IOM does not have the ECG. We do the radiology services, but the ECG, we don't have it right now within the clinic. So we would refer you to go to another hospital for that specific service in this case. But for the COVID test, for travelers, a few have been done at the clinic, and in the long run, we are going to be doing it also for people traveling. However, that will be at a cost of about $65 for those who are traveling, those going on annual leave, any other purpose other than the intentions of the COVID response, you'll definitely have to pay. Thank you.
Okay, thank you very much, Ursula. I think that answers the question. Tatsu?
Sure. Let me go through the next, go on to the next question. Yes, there was a question on the cost for test at the IOM clinic. It is just now clarified. There was a question about reinfection of the COVID. So does it mean that recovered patient can only be reinfected with the same strain that has earlier infected them in the first place? Probably this is partially, I believe, answered, but maybe if Jonas or any other WHO colleagues have further clarifications.
Okay, let me try. A certain level of immunity is acquired when one gets infected, although there are still studies looking into for how long that immunity is continuing. But the coronavirus has changed a bit, and there are close to or over 100 strains. So what has been recorded in less than a dozen cases is that people who have been known to have recovered were infected with a different strain as a second time, some mild and some even more severe. So it's important, at least for most of us, to ensure that we follow the public health measures so that it is possible that we avoid second round of infection. That's one. But what the other thing is, the last 2 days, a report on the vaccines and other aspects of immunity has indicated that the immunity acquired is not as short as we used to think. It might be longer, but as this is a new disease, we are still trying to discover what is the full picture of how it infects, how it develops immunity, how long does the immunity last, what's the effect on the vaccine, as well as second infection is concerned. But definitely there are possibilities of second infection. So the preventive measures are required not to get a second strain of the disease affecting the person again. Over.
Thank you very much, Jonas. Then the next question is, kindly comment on the plans to keep Nakasero-based UN agency staff safe during the election period. It is much more for the DSS related questions, I guess. Do we have any answers from the colleagues?
So let me take that. First of all, there is no reason why we would only focus on Nakasero. As I mentioned in my remarks, we have a contingency plan for all UN personnel in the territory of the Republic of Uganda. The UN Security Cell has developed an elections contingency plan which has been adopted by the SMT and which will be updated on a regular basis going forward. On that basis, safe havens have been identified, mitigation measures have been identified, and the different teams will begin to be briefed as of early next week. So we will not be just talking about one group. We will do our best to ensure the safety and security of all personnel and dependents in the country who are recognized by the United Nations. As I mentioned in my remarks, please take the time to sit down with your security focal point in your agency to understand what is your role and what you're supposed to do in case of a problem. If you do not, if you cannot reach your security officer or you want additional information, please reach out to DSS and they will make that briefing available to you. Make sure you know who your warden is, make sure you know what to do and what the UN expects you to do should the situation deteriorate further.
Thank you very much, Rosa. Then let's move on to the next question. There are further some additional questions on the testing, part of which may have been already answered, but if any lab samples can be collected from home, that is one question. And there was another follow-up question for the travelers. What if you are traveling on official duty outside of the country? Can you be tested for free of charge, at least from the personal, at the personal level? Do we have maybe IOM colleagues, I guess?
Thank you very much. Okay.
In terms of
Mokunda, take it. We have provide answers to this question. I already posted it on the chat box, the answer, but Mokunda, maybe you can do it better.
In terms of the sample collection at home, mostly it is done for those who have who cannot actually come to the clinic for providing the sample, especially very sick people or those who needs a follow-up sample collection are already tested positive and request follow-up sample collection. In terms of the testing for the travel, yes, the rule is the same, whether it is official or unofficial duty. This testing, this kind of services for the travel testing requires the fee, and which is already mentioned at $65. Thank you.
Sure. Thank you very much, IOM colleagues. And the next question is, how long does the virus last on surfaces? There was instructions on the cleanings, but maybe WHO colleagues can elaborate a little bit further.
Innocent, maybe you can answer that. Alex, we lost Innocent.
Thank you very much, Gabriel. According to the literature which we have been reading so far, the virus can stay between 4 to 9 hours depending on the type of surface you are dealing with. So you can actually have the virus in the surfaces for some time. That's the information which I have. Thank you.
One thing I want to add is still our understanding of the virus continues to evolve. As you might have read in plastics and other things, it can stay for days. But it's important to note that it's also a fragile virus, which its membrane can easily be dissolved by soap or alcohol. So ensuring frequent and thorough cleaning would be the guarantee. Over.
Thank you very much, WHO colleagues, for clarifications. I guess that really reconfirms the importance of the cleaning on a frequent basis. So let's move to the next question. It's about the risk assessment. How often should risk assessment for work-related exposure of COVID-19 to be done?
Let me put it this way. There is an organizational risk and there is a community or individual risk. What COVID tells us is that we have to balance the risk on a day-to-day, on an hour-to-hour basis. When we decide to meet the number of people we want to meet, where we want to meet. The moment we pick something which we know is not ours, whether it's a glass or it is a phone of somebody else, we have to judge the risk. There is a risk. So, and then take the measures to minimize those risks by washing hands, by using sanitizers, limiting our contacts, keeping distances. So basically in COVID, because the risk is not as apparent when we see it as it is, we have to judge in this changing situation and decide the risks versus what we wanted to achieve. So that balancing act will be an everyday life event until we have the vaccines and take the measures to minimize those risks. But as an organization, I think that should be done frequently and when situations change. When there is, for example, a contact within an office, we do the risk analysis again. When we need to increase the number of staff, we have to do that analysis. When we want to venture in a new geographical area or in a new area of activities, we do that risk assessment. So it's a constant modification of our risks and our activities. Over.
Thank you very much, Jonas. Let's move on to the next question. I see a question on the insurance and the family member not covered by insurance, but I believe this question was already answered. In terms of insurance, one needs to consult with HL, and the IOM services available to your staff and dependents. That's, I believe, what we have already heard from colleagues. So let's move on to the next question. Given the rising cases in Uganda today, do you see a situation of total or partial lockdowns again, as we are seeing in Europe and the United States?
I think that's a very difficult decision the government has to make, considering the political, economical, and other aspects. There are the good and the bad aspects of lockdown, and that has to be evaluated. Do I foresee in the near future? I don't. But when the health services have reached a certain stage, the government has to consider geographical lockdowns or areas of activities lockdown. But what we are trying to prevent by taking the preventative measures and building the capacity of the health services is for such lockdowns not to be essential or necessary.
Sure, thank you very much. The next question is about immunity against disease. I believe this was already mostly answered by the previous questions on the vitamins, but I wonder if there's any addition to WHO from WHO colleagues, or otherwise we can move on to the next question.
Next.
Sure. Let's move on to the next. Again, IOM test, that was already, I believe, answered. Okay, the next question is, do you have any advice on the use of ventilations and air conditioning at workplace?
Most of the air conditioning apparatus don't have sufficient filtering capacity. So we discourage the use of air conditioning in the office or in the car when there is some other person than the person driving it or from outside a single family setup. I think the weather in Uganda is good, so the best ventilation is to open your windows. First thing you go into your office or into a room and ventilate it, and only close it when you leave or when you are threatened with rain. Over.
Thank you very much. Next question was men more at risk. I think there was already an answer on the gender disaggregated data. So maybe we could move on to the next one. Next one is, if one is asymptomatic, we would expect that person not to infect others because of not having symptoms. Why is it not the case? There was, yes, already an explanation about asymptomatic cases, but maybe there could be some elaborations, or leave it to WHO colleagues.
Innocent or Alex could, maybe Salome can answer some of the questions. I see she is also around.
Okay.
Alex, Salome, go ahead.
All right. Thank you very much for the question. On the asymptomatic transmission, what has been shown is that for individuals that do develop symptoms in the days prior to developing the symptoms, at least 2 to 3 days before, it's still possible for you to be shedding virus, and therefore it's possible to transmit. There has also been a bit of literature around transmission from completely asymptomatics, but then that was in very specific conditions. But also realizing that you might not know whether you're going to be in the symptomatic or asymptomatic group. It's always important to take precautions so that in any case, the chance of transmission is reduced. I think that's what I can say. Thank you.
Okay, thank you very much, Salome. There are some more questions on asymptomatic cases, but I believe most of those were addressed. So let's move to the next one. Okay, there's a question about the testing. How quickly can you test positive after having been exposed to the virus? So how many days do you need to be able to detect the virus after you were exposed?
As shown in Innocent's presentation, usually it is between 2 to 5 days after exposure that we see the earliest positive cases. But that positivity can
maybe just to add a little bit, it can be 2 to 5 days, but you realize some people can even go beyond 5 days. We can go up to 10 to 14 days. But the soonest is what WHO just up.
Alex, go ahead.
I was saying that the incubation period, like what you rightly said, the earliest signs and symptoms can appear within 2 to 5 days. But you realize that some people can go beyond 5 days. They'll start showing symptoms from 10 to day 14. So it is always good to make sure that one is protected and one is tested even after day 5. Thank you.
Thank you very much for clarification. Let's move on to the next. Next is for staff going back home for holiday season to countries not requesting to quarantine or even not requesting a PCR test. Would you recommend to have a second PCR test done on arrival in addition to the test mandated before the departure? The same applies for return to Uganda.
Solomon, you might like to answer.
Okay, I will answer that. The current guidance from the Ministry of Foreign Affairs and from the Civil Aviation Authority is that to exit Uganda, you do need a negative test at least 72 hours prior to the travel. So that is a prerequisite, whether the country you're going to requires the test or not. So until the Civil Aviation Authority or Ministry of Foreign Affairs changes that requirement, we still do have to do that test upon exit. On returning, the requirement is for us to do a test, have a negative test done 72 hours prior to travel coming back into Uganda. So it is a requirement. And upon arrival in Uganda, the guidance is for you to go into self-quarantine for at least 10 to 14 days after arrival. So it's not simply coming back and then going out into the community, whether you had a negative test or not. That is the current guidance.
That should allow me for 10 minutes to hand over to Alex to moderate, please. Thank you.
Sure. Thank you very much.
Just in addition, Tatsu, whilst Deborah maybe is changing his area, it is also important to realize that testing when you're traveling home, it is not meant for the authorities. It is actually meant to protect yourself, also to protect the family in which you are going to be staying with. So in some areas, you can have test day 1 when you enter your country, you're leaving Uganda. Then you can also have a test on day 10, day 14, just to make sure that you were not carrying the virus, it not incubate during that particular time when you're traveling and when you're at home. So the whole idea of testing is to protect yourself and protect your families. Thank you.
Yeah, thank you very much, WHO colleagues. There are a couple of more questions about the cleanings and the surfaces, how long virus stay. Okay, maybe you can answer in one go. So one question is, how long can the virus stay in the room if the cleaner shades the virus while cleaning? I think this is already partially answered, but there was another question on cleaning. Can we have cleaners from companies who deep cleaning to do so over the weekend and leave it up to staff to clean surfaces of their desk furniture during other days of the week? Maybe WHO colleagues can address this.
Thank you very much. When it comes to cleaning, our practice, we have deep cleaning on a weekend, that is from WHO side. But during the working hours, we cleaners focusing on specific areas. They focus on door handles, they focus on table, they can focus on those areas where we can have a challenge. My computer, like in my case, I do my own cleaning of the computer, which can actually recommend to most of the computer users, because you're the one using it. It is always good to make sure that you can make that arrangement within the office to say, who is going to do the cleaning, which items am I going to do self-cleaning, items do I need an external support? That's the response I can give.
Okay, thank you very much. There are one question again about IOM's test. Can you have antibody test at the IOM? Do you have anything to add from IOM colleagues on antibody test?
So let's say, I'll refer that to Dr. Mkunda or Ursula if she is online.
So let me let me respond on that question. We don't have an antibody test. The current testing is the current testing protocol is that we are doing the PCR test for the COVID.
Thank you very much.
Just to add that the country is now looking at the issue of the rapid diagnostic test kits, which are being introduced, but this is still a lower number. They are still small numbers, and they'll be working on training. Once this actually improves, then this can be rolled out to many areas. Thank you.
Thank you very much, IOM and the WHO colleagues. Then the next question is, it's the antibody, seems like a question on the antibodies again, but the question is, how long does IgA antibody develop into the body post-COVID-19 infection in correlation to long-term immune response and conferring protective immunity?
I can refer that to Solomi and Dr. Mkunda.
Thank you very much, Alex. So we always have the IgM and IgG antibodies following an infection. So you would have the first set of IgM showing up from around day 4 or 5, and then the IgG following at about day 10 in this particular infection. The IgM will then start to reduce and wane between day 14 and 21, but it's always something that's available for a very short time. There are still studies ongoing to see how long that IgG will last, and I think that is the basis of what the issues to do with the vaccine development are focusing on, and then also on the question that was asked earlier about reinfections. So I think that is the simplest explanation that I can give. But if I may communicate that for the purpose of diagnosing and making sure that you know whether someone has COVID or not, the focus should not be on looking for the antibodies, but it should be focused on doing the PCR tests that are currently available at IOM, or these rapid tests that are antigen that are being rolled out, that are early in rollout by the Ministry of Health. I thought that it's important to mention that.
Sure. Thank you very much. Okay, now it seems like so far we have exhausted questions on the question and answer box. I have a couple of more questions that I see seems to be not addressed, or there can be some room for elaboration. So I will come back to a couple of questions on the comment boxes. So the one question is on the vaccines. So the question was, do we have vaccines that produces strong immune response in adults? But maybe WHO colleagues, you could probably elaborate further on the status of the vaccines development.
Thank you very much. Just to let me refer that question to Dr. Annette. She's the one who deals with vaccines from our side. Dr. Annette.
Thank you very much. There was a question about Uganda participating in the vaccine development. I've answered that on the chat, that yes, Uganda is in the process, but it's a collaboration between different institutes following the presidential initiative where they provided funding. Now, two, at the global level, there are over 100 vaccine candidates, but in the different phases of development. And as of 10th of this month, around 9 of them were in the phase 3. And already 2 have started publishing their information, but of course that data has to be submitted to WHO for further scrutiny, and then they will give us a go ahead, whether they're approved for emergency use listing. Thereafter, then the pre-qualification process will start. So there are several candidate vaccines. Now, thirdly, under the COVAX facility, which I earlier mentioned, there are already 9 candidate vaccines. And of those 9, one of them is the Moderna, which was published recently this week, which is already in phase 3. And there's another vaccine, which is already in the phase 3 of the clinical development. So that several vaccines, but at different stages of development. Over to you. I hope I've been able to answer that question. Over.
Sure. Thank you very much. There are 2 more questions in the comment box, so I can read them probably in one go. There is one quick question on, please give some information on the post-COVID side effects. So probably WHO colleagues can address that. Then another question is actually a different question. For the coordination of any support to affected staff, what is the expected level of involvement of the UNACs and RCOs in different regions? So those are 2 questions. Maybe let's start from the one on the side effect.
This again, I will refer this to Solomon and Dr. Annette will take off this. And if the W is online again, you can take care of part of that. But these are clinical issues. Solomon, over to you on the clinical issues.
Okay, thank you very much, Alex. Right now, as of now, most evidence on the post-COVID effects are mainly on the lungs. So individuals that have had the infection continue with some difficulty in breathing. So you'd see people having difficulty in exercising, in doing their routine activities. And this is mainly because as the person is healing from the COVID, they are healing with a lot of scars in the lungs, something called fibrosis. So that causes a bit of stiffness in the lungs, making it a bit difficult for you to breathe in and out as would normally happen. I think that is the most commonly documented post-COVID side effect, but also there are others depending on whether the heart was infected in the illness or the kidneys. But the most significant really is that that problem with the lungs, where people find it hard to breathe normally. Thank you. I don't know if Dr. Annette has something to add on that.
No, nothing to add on. Thank you.
Now, if I may add, also there is some findings which suggest that COVID itself might cause damage the multiple organs, where people might develop hypertension or even diabetes associated in people who are not previously known to be diabetic or hypertension. But those research are still going on. Definitely, we think as a multi-organ disease, there might be long-lasting effects, which we would only know as time proceeds. As I said earlier, this is one disease which we are not fully aware of its long-term effects. Or
Sure. Thank you very much. And the another question was on the involvement of the UNACs and RCOs in different regions. Rosa, would you like to mention about that, or shall I answer to that?
Involvement in what?
Well, the question was for the coordination of any support to affected staff, what is the expected level of involvement of the UNACs and RCO in the different regions?
Okay, so the head of the UN area coordination team and where we do have an RCO staff, number one is to make sure that all the staff in the region are aware of who the regional medical focal point is, as was mentioned in the presentation by WHO, as well as the presentation by Dr. Teferi. So that is what you need to make sure that is done, to make sure that staff are aware, this is their focal point and what they're supposed to do. The second thing that you're supposed to do in terms of your role is to help disseminate information. So the staff advisors that we're giving out, the updates that we're giving out, the telephone numbers that we're giving out, to make sure that staff know that should you have any suspicion whatsoever, should you have any concern whatsoever, you to write to your representative and the UN doctor so that we can support you accordingly. So your work is just facilitating, making sure they get the right information. And if we need additional support at a later stage, we will let you know.
Sure. Thank you very much, Rosa. I thought I exhausted questions, but we got quick 2 more questions in the comments, and seems like the questions are coming in. But we will, if we don't pick up all the questions today, we will try to come back with staff advisories or any other documentations that may that are coming in the future to address those questions as much as possible. But in any case, let's just take 2 more final questions. So please give us the definition of the local mission required. So the question is basically the 10 days of isolation after the local mission. Maybe you can elaborate this more. Probably the question is about why is it 10 days while, for example, the other self-isolation is 14 days, etc.
But thank you very much, Tasso. From the presentation, which we've been discussing, and also looking at the incubation periods, there are 2 things which you need to consider here. When you talk about the incubation period, you're talking about the period where the signs and symptoms are likely to be showing in a person, and you can tell a person, what the Deborah said, 2 to 5 days it can start showing. What has been noticed that by day 10, most of the people who show signs and symptoms, they should be actually showing that they have COVID within their system. The maximum period you can show is 14 days. But based on the fact that most of them have been showing signs and symptoms or testing positive at 10, that's the reason why some organizations and from our presentation, we're recommending that you can do the 10 days isolation. So by 10 days, we are saying signs and symptoms should be showing. That is why we're sticking to 10 days, up to 14 days being the maximum. But there's nothing wrong in testing someone in day 14. But we say logically, and looking at the time, we are focusing on day 10. Thank you.
Thank you very much. And the last question in the comment box is again about preventing discrimination of former COVID-19 affected colleagues. There was already a question about the stigma, but this question is specifically about the colleagues who have been affected by COVID-19. Do we have any colleagues maybe from WHO or any other agencies who would like to address this question?
I could refer to UNICEF to come on board on this one.
Just once again, can you paraphrase it again, Sasu?
Sure. The question is, what have been done so far to prevent discrimination of former COVID-19 affected colleagues? So the previous question was on stigma, on the community's activities, etc. But this question is specifically about colleagues who are affected COVID-19.
You mean within the organization? Okay. Alex, it's interesting you referred it to me, but I'll take it all the same. I think the what. Let me just take
a risky question. I can answer it.
No, I'll start and then Jonas will pick it. I think for us, what we have done within UNICEF is we have had meetings where we have been able to discuss. I think in a very general terms, we have got presentations which we have got from our headquarters, we have got from our regional office, and it's just having this kind of dialogues like we're having today. It's an issue which keeps coming up on the way cases are being handled. We have got the global guidance of confidentiality, of not really being able to announce the cases. And what we have encouraged is that when people are free and they're willing to talk about their case, they should do it. When they want to remain quiet about their case, we should also respect that. I would like to say that from my end, I've so far not seen any case of discrimination, but that does not mean it's not there. But I've not been able to experience it because we have also not had so many cases within Uganda. So I think maybe Dr. Jonas, you can pick it from here.
Right, thank you very much for that explanation, UNICEF rep. Let's go to Dabia.
It's important to engage WHO and the UN doctor so that we can help you. And if there are any signs of discrimination, we can work with colleagues and the communities to create the awareness so that they understand there is nothing wrong to recover from COVID. I think this being a new disease, and just like what we saw in Ebola and so forth, it is important to educate our colleagues and communities to manage this discrimination. But I would also ask Karusa, who had a lot of experience in HIV cases, that we can manage discrimination by educating people. Maybe Karusa could comment.
Do you still have Dr. Karusa online or CDE? UNA's colleagues?
Yes, today is online. I think Dr. Jonas has said it best, but if I can just add, maybe the reason why we're always advocating for community actors to be involved from the get-go, working with the National Task Force, is because if the community isn't the know to start with, people within the community seem to trust their own people naturally. So that's why we're always advocating people from the community to be involved in the different sectors of the pillars to start with when working with the National Task Force to respond to the COVID. So my belief, and I think, if I may speak for Karusa, is the involvement of community is huge, and it should continue. They should be part of this response. Over to you. Thank you.
Okay.
Thank you very much, Alcide. Thank you, Dabia. Thank you, UNICEF rep. I think what is important, colleagues, is to understand that if one gets COVID within the workplace, it is important to have a supportive mechanism. I know that you and a clinic, they do have a psychosocial specialist who can also support the infected person. But let's try to make it a culture that all the people in the office should understand that you can get COVID, I can get COVID. So there's no reason why we should actually stigmatize our colleagues if they happen to get it. So let's try to build that culture going forward. Thank you. Back to Side. To Tasu.
Okay, fine. Maybe let me come in quickly on this. Let me just mention that we have a very good team IOM, us WHO, UN Clinic, and we have a very good team of clinicians. So for all those who test positive for COVID, we actually review all their situations one by one, and then we are able to actually make a decision about them, especially those who require a decision of any kind, clinical or anything. So, and in this way, we have actually tried to minimize the issue of discrimination. I think that we have reviewed quite a handful of cases. There are also some of the people, including contacts, some of them just contacts, they're not even cases, suspected, and the like, where we have they have required psychosocial support. We have tried to leverage on whatever colleagues can provide psychosocial support to ensure that they get psychosocial support. So by working as a team, we have actually been able to minimize significantly any feeling of discrimination in the care of the COVID patients. But if there are any persons who feel that they have been discriminated about, I think they can bring this to the UN doctor, and then through that we can put it together. There are many ways this come to our team, but whichever situation arise, we always try to ensure that we discuss them together and see how they are resolved in the most neutral possible way. I think this is how we have done it, and this is the process that we have been. That's my contribution. That's all.
Right, thank you, Innocent. Back to Tatsu. I think we're left with 50 minutes. Tatsu, let's speak on the last ones. Then we have the WR and RC coming back.
Yes, I think I believe that we have exhausted questions on the chat box. So there might be some additional questions that colleagues may have, but we will let's try to address that in coming maybe future staff advisories and any other documentations. Or maybe we could request Jonas to address a couple of questions probably in the closing remarks. But I think with that, we can bring the floor back to the chair. So maybe, yes, Rosa, please.
So I would like to invite Dr. Jonas to please make the closing remarks. But before I do that, I really want to thank all the colleagues who have helped to respond to all the questions. And I want to thank the staff for coming forward and asking those questions. Jonas, over to you.
Thank you very much, Rosa, and colleagues who contributed in organizing and being as a panelist or in any other aspects. And most of all, thank you for all the staff who participated in a really active way. We intend to repeat this kind of webinars. Our next focus will be caring for oneself and the family, looking into home-based care. And even if not home-based care, what are the precautions one needs to do at home and in social surroundings. But my message is COVID proves that your health is in your hands. It's you who would be able to evaluate the risks and take a decision of what you need to do and what you do not need to do. Wear your mask, hand sanitizing, keep a distance. Physical distancing is important. Avoid, if you can do it outside, do it outside. Avoid in-house and crowded places. And if you do all that, you would also contribute to the disease not being transmitted to those who we love and those who we cherish and those colleagues we admire. So my plea to all of you is, this is a serious disease. Take it seriously, but know that if you do your part, it's an easy disease to control if all of us ensure that we take the public health measures. Thank you very much for all of you. Thank you.
Thank you very much, Jonas, and through you to the entire WHO team. Dear colleagues, before closing, I want to once again convey our profound appreciation to all our colleagues who are working to make sure that we can get the knowledge that we need to make the right decisions and to make sure that we can stay healthy, and when something is wrong, to make sure we have access to the right care. I also want to convey my appreciation to all the staff at the front line, having to be out there to make sure that those who depend on us to stay alive can do so. As I mentioned in some of the chats, it is up to us to engage with the government and with our partners to encourage them to make sure that meetings take into consideration the COVID-19 preventive measures. Safety, health are all in our hands, for ourselves of individuals, for our families, for our communities, and for the people we serve. So thank you once again for participating. We look forward to having our next session, but in the meantime, please meet in smaller groups. Please not hesitate to share questions, and please be ready to take the necessary action as we do our best to learn to live with COVID-19. Stay safe, and we'll be in touch again. Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.
Thank you.
Thank you.
Rosa, thank you, colleagues. Bye-bye.
Bye-bye.
Thank you very much, colleagues.
Well done. Thank you.
Thank you, WHO. Thank you, Jonas.
Thank you, IOM. Thank you.
Thank you, Rosa.
Thank you, everyone. Thank you, WFP, UNHCR, FAO, UNAIDS, UNICEF. Thank you, everyone. Thank you, NDP. Thank you. Thank you to the organizing committee. Thank you.
Okay, Kali. Okay, I'm exiting it now.